Okay, so now we're on to chapter 28. Okay, so now we're on chapter 28, which covers some obstructive diseases. So some of these will cover our asthma, COPD, that includes your chronic bronchitis and your emphysema, and there are some others. We'll get to them. Okay, so first of all, asthma, a respiratory disease characterized by a combination of clinical manifestations. There is reversible expiratory limitation or bronchial hyperresponsiveness. It consists of unpredictable periods of adequate control to periods of exacerbations. Signs and symptoms would include wheezing, but not always, breathlessness, chest tightness, coughing, and symptoms are usually worsening at night or early morning. Okay, more on asthma, some risk factors and or triggers for asthma. So risk factors, one of them is rates in African Americans are 38% higher. Women are more likely to have asthma, except in children, males are more likely to have asthma. Genetics does play some role in asthma, or immune response, allergens that people might have. Exercise can induce asthma reactions. Air pollutants, also occupational factors. Do they work in construction where they're dealing with fine dust particles or coal? Here in western Kansas, where we deal with our crops and sprays that they use. Respiratory tract infections can also precipitate some asthma problems, nose and sinus problems like having polyps or lots of drainage because of allergens. Some drugs and food additives also can precipitate asthma. And there is a link between asthma and gastroesophageal reflux disease, or also known as GERD. And then there are psychological factors. It's not a behavioral health disease, but asthma and not being able to breathe does produce some anxiety and anxiety-related problems, which further increases the problems with asthma. Okay, so basically the pathophysiology of asthma is that the airflow is limited because of an inflammation response. That results in bronchoconstriction, the airway hyperresponsiveness, edema in the airways, like I already explained. But anyway, the inflammatory process, there's a picture here about triggers, how it triggered the allergen. So mast cells degranulate and release multiple inflammatory mediators. So the IgE antibodies that are linked to mast cells and the allergens, basically the inflammatory mediators in our body like the leukotrienes, histamines, cytokines, prostaglandins. So a lot of what I've already talked about in somebody who has rhinitis because of allergies. So if you want the simple term of what asthma is, it's an exaggerated immune response resulting in airway inflammation. So yes, sometimes there is an excess of mucus from this inflammatory response, but basically asthma is restriction, either by constriction of the bronchioles or constriction caused by mucus. So an exaggerated immune response resulting in airway inflammation. So if I ask you, why is respiratory function altered in asthma? It's because there is an increase in airway constriction. So therefore, that's why we hear that wheezing going on, especially that expiratory wheezing. They're trying to blow that air out, and there's constriction. So it makes the noise, that musical noise, as air is leaving the lungs. Okay, some clinical manifestations of asthma, signs and symptoms, like I discussed in slide 1. There could be dyspnea or difficulty breathing after that trigger. So it's not always an allergen. It could be like cold air could be a trigger also. Some of those things I talked about. Prolonged expiration is also a sign or symptom or clinical manifestation. So remember me talking in the assessment portion, we talked about there's a 1 to 2 ratio of normal inspiration versus expiration. Well, in asthma, there may be prolonged expiration like a 1 to 3 ratio or a 1 to 4. Also, signs and symptoms, air trapping could be bronchospasm or hyperinflation of the lungs. So often, here we go again, we're going to be hearing that expiratory wheezing. Sometimes inspiratory also, but expiratory is your main. And then they're going to be coughing, and that could be with or without secretions. So most probably they're going to have secretions that's also causing constriction of the airways. And it's usually thick, white, tenacious mucus. So think about ways we're going to keep this mucus thin, either by meds, by increasing fluids, all that. Then there are some classifications of asthma. You don't really need to memorize those, but just know this is like how to determine the severity. There's intermittent type, mild persistent, moderate persistent, and severe persistent. Okay, some complications of asthma. Some complications of asthma could include status asthmaticus, which I believe you guys did in your lab. You practiced with the simulators, taking care of somebody in a severe asthma attack. So you know that can be a life-threatening situation. Some diagnostic studies would be on Table 28-4, page 544. So you can look at that. You're going to be getting your pulse ox monitoring of your oxygen saturations, maybe some ABGs, maybe some of the same diagnostic studies we've already talked about, maybe an x-ray. Our collaborative care depends on how bad the asthma attack is. You can look on page 546. There's a table 28-7, classifications of acute asthma exacerbations, and what we would do clinically to treat that. So mild, intermittent, can be treated at home usually. So they're going to use their rescue inhaler or their albuterol inhaler. Sometimes they may need some oral corticosteroids to decrease that inflammation also. Then there's moderate and severe, which usually requires them to go to the emergency department. So we're going to be using our rescue inhalers, going to be using some corticosteroids, our bronchodilators to open up those airways. Um, and then if it's life-threatening, of course, they're going to be in the hospital, possibly even the intensive care unit, and they're usually too dyspneic to speak. They might be drowsy or confused, sweating, things like that. We're going to be giving some IV corticosteroids for them and breathing treatments, just anything to get that airway opened up. Maybe some epinephrine. Drug therapy for asthma is mainly going to be your bronchodilators to open up the airways, your antihistamines to block those allergens that are causing some, or I shouldn't just say allergens, but block those triggers that are causing the constriction, and your corticosteroids that are going to decrease inflammation. And then our drug therapy continued for asthma, our bronchodilators. There's different types. I don't want you to know, you don't have to dig deep into knowing the different types. Just know bronchodilators are used for the constriction from asthma. But I do want you to know the patient teaching related to drug therapy. So a lot of your bronchodilators are going to cause increased blood pressure, increased heart rate. They might cause dysrhythmias, so have the patient be aware of that. That increased heart rate and blood pressure may also add to their anxiety that they're already having from not breathing well. So if anybody has any heart disorders, we want to consider that with our drug treatments. So what else would be in your patient teaching? Probably rinsing their mouth out after they use these inhalers. With our nebulizers, how we're going to clean the nebulizer. Also, that they need to carry their rescue inhaler with them. What if they have an acute exasperation and they don't have that? So those would be in the teaching. When we look at asthma with the nursing process, we're going to, of course, do our assessment. We've already talked about those different assessment things. Some of our nursing diagnoses that we may use for asthma, of course, we're going to direct this to the patient, so whatever they're experiencing. But some of them may be ineffective airway clearance. They can't cough up the mucus. Anxiety is definitely going to be one of those, and deficient knowledge is going to be another nursing diagnosis. So just be aware of those different types of nursing diagnoses that are frequently used with asthma. Let me touch back on ineffective airway clearance. That's not just getting the mucus out. We don't have the clearance because of the constriction. The air can't get in and out. We don't have that exchange of oxygen and carbon dioxide going on. So then of course your planning, then your implementation. So your implementation, we want to think about not just while they're sick, but let's teach them about health promotion and prevention of their asthma exasperation so that we can keep them healthy in the first place. And then of course our acute interventions if they are currently struggling. And then ambulatory care, which means care after hospitalization or home care. And then our evaluation. What would be our expected outcomes and have they been met? So you can think about what those outcomes would be. Our respiratory rate has decreased to a normal rate now. Wheezing is absent. Those type of things to evaluate if they've gotten better or not. Maybe they have a decreased incidences of asthma attacks, etc. Okay, now we're on to COPD, or chronic obstructive pulmonary disease, which previously I was always taught that these are a group of diseases that could be considered COPD. Chronic bronchitis, emphysema, and even your chronic asthma. But now your book is saying previous definitions of COPD have included such terms as chronic bronchitis and emphysema, but neither term is a part of the current definition of COPD. So I'm not quite positive on what that's saying, that these diseases are now separate, but they're still grouping them in the same COPD group in your book. So anyway, the pathophysiology of COPD is a preventable and treatable disease characterized by persistent airflow limitations. It's usually progressive. It's associated with enhanced chronic inflammatory response in the airways and lungs, primarily caused by cigarette smoking and other noxious particles and gas. COPD also has exacerbations like asthma, and if they have coexisting illnesses, that can contribute to the overall severity of the disease. So we will talk about the different classifications of COPD, which are the chronic bronchitis and emphysema mainly. So here's our chronic bronchitis. So to have a medical diagnosis of chronic bronchitis, the criteria is there's a presence of a chronic productive cough for 3 or more months in each of 2 successive years. So 2 years in a row, they've had a cough for 3 months or more each year. They would qualify for this diagnosis. So a good way to remember your chronic bronchitis part of COPD type diseases is the blue bloater. So I put a picture here. There's an airway flow problem. Their color is usually dusky to cyanotic. They have recurrent cough and increased sputum production. They have hypoxia, hypercapnia, an increase in the carbon dioxide. They're not able to blow that carbon dioxide out effectively because something's going on in their alveoli. Usually they're slightly respiratory acidotic. They usually have an increase in hemoglobin, increased respiratory rate. Exertional dyspnea, that means they're having dyspnea with their activities. Usually smokers develop this. There can be clubbing in the fingers. There's usually cardiac enlargement, use of accessory muscles to breathe when they're having exasperations, and it can lead to right-sided heart failure. They may have bilateral pedal edema, which means in the feet, and increased jugular vein distension. So you'll notice that increase in their neck, that jugular vein is really sticking out. So the blue bloater, that's a way you can visualize how to differentiate between your chronic bronchitis and your chronic emphysema that we'll talk about next. Okay, here's your emphysema. Emphysema is the abnormal permanent enlargement of the airspace distal to the terminal bronchioles, and destruction of bronchioles without obvious fibrosis. And fibrosis would be like the scarring of them. So here you can see some different types of abnormal enlargement of the terminal bronchioles. You don't need to know the difference, the central lobular and the panlobular, but just know that this is an enlargement of that airspace. So here's our pink puffer that we can think of emphysema with. Remember, the blue bloater was kind of a puffed up guy. And now this guy, he's pretty thin and barrel chest looking. So our pink puffer, or our pulmonary emphysema dude here, also has increased carbon dioxide retention, which is making him look pink instead of cyanosis like we see in chronic bronchitis. We see them with the pursed lip breathing. They have dyspnea. They have an ineffective cough, which means they're not able to bring up stuff. They're not coughing deep enough. There's hyperresonance when you percuss over the chest. They're usually orthopnic, meaning when they stand up or do things, they have difficulty breathing. The barrel chest appearance, exertional dyspnea on exertion, prolonged expiratory time, just like we saw in asthma. Instead of that 1-to-2 ratio, there's like a 1-to-3 or 1-to-4 ratio. They often speak in short, jerky sentences because of their difficulty breathing. They're usually anxious. They're using accessory muscles also to breathe. They have that thin appearance, and it leads to right-sided heart failure also. So there's some visual aid for you to differentiate between chronic bronchitis and your emphysema. So here are some more of the complications that can occur. They talk about that in your book, page 563 to 565. So cor pulmonale is one serious complication, and that basically results from pulmonary hypertension, which is a late manifestation of COPD. So it's basically caused by a constriction of the pulmonary vessels in response to hypoxia. Okay, exacerbations of COPD is another complication. You can read on page 564 the acute exacerbations. Also, acute respiratory failure. That just basically means they're going to stop breathing. They talk about it more in chapter 67. If you just know acute respiratory failure is a complication, it can eventually lead to this, which of course would cause death. Other complications would include peptic ulcer disease and gastroesophageal reflux disease, or GERD. And then, of course, depression and anxiety related to not being able to breathe and do the things that they regularly did. For COPD, we have our diagnostic studies, which we have already talked about those in previous lessons. Our collaborative care, so number 1 would be smoking cessation. Also some drug therapy for them, and probably some oxygen therapy. So you can look at the indications for oxygen therapy. Just remember with COPD, in the next slide or two, we'll discuss that hypoxic drive. So just because they can't catch their breath does not mean that we increase the oxygen amount they're receiving. That could be bad. So our methods of administration for oxygen, there's different ways. These are all listed on 565. Either it's through a nasal cannula or a mask if they need higher levels, or if they're mouth breathers. And then also humidification and nebulizers are important too. If they're receiving a lot of oxygen, oxygen's very drying. It has an irritating effect on mucous membranes, and it dries secretions, so their cough would not be productive. So it's important that if they're receiving a lot of oxygen, that we put that bubble through humidifier on there. And remember, we fill that with either sterile water, but most of the time it's just distilled water that we use in those. Some other complications that might result with oxygenation and COPD would be combustion. You need to teach them that oxygen is highly combustible. So if somebody's on oxygen, there needs to be a sign on their door. At their house, there needs to be a sign indicating there's oxygen in use. Also, you need to tell them they can't be smoking around oxygen. They will catch their faces on fire. I've seen a lot of people that are smoking around it. Even with their tank, they can't just shut it off and smoke around it. They need to. If they are going to continue to smoke, they need to leave their oxygen inside and go outside to smoke, completely away from that oxygen. So, and also related to combustion, we wouldn't want to be using petrolatum, like Vaseline type of things around them on their lips. They need some water-based lubricant instead. And so not only smoking, but any open flames can't be around the oxygen. Okay, carbon dioxide narcosis is that hypoxic drive I was talking about. Talks about it on page 565. So the respiratory center that controls the drive to breathe responds to CO2 and O2. So remember, in the brain, it's detecting the carbon dioxide levels and the pH, but then those other peripheral receptors are responding to oxygen levels. So the accumulation of carbon dioxide, like most people with COPD have, not all, but most, it's the major stimulant of the respiratory center. So over time, COPD patients with hypercapnia, or that increased CO2 level, they lose sensitivity to those elevated levels. So theoretically, for these individuals, a major drive to breathe is hypoxemia. So they do have the low oxygen levels, and that's keeping them breathing. So there's a concern regarding the dangers of administering too much oxygen to COPD patients that would reduce their drive to breathe. So it's a complex system, and mainly just know in the brain we have those receptors that are the CO2 levels are telling us to breathe more, and our peripheral receptors have oxygen that's sending or detecting oxygen levels that are sending messages to tell us to breathe. And in people with COPD, these levels become desensitized. So that's why we don't, if they're on 2 liters of oxygen, we're not going to just turn them up to 5 liters or 4 liters if they're not breathing adequately. So our main goal with oxygen therapy is to keep it above 90%. So it may not be at that 95% level where we want to see everybody at. But so we would be checking their pulse oximetry and their ABGs to determine, well, the doctor would, to determine what level of oxygen they need to be on. Okay, and then O2 toxicity refers to too much oxygen. So that too much oxygen can result in a severe inflammatory response. It can damage alveolar capillary membranes, resulting in pulmonary edema, shunting of blood, and hypoxemia. Even there's too much oxygen. So the amount of oxygen we give somebody with COPD needs to be just enough to maintain that oxygen within an acceptable range. Okay, and then infection. Well, here, of course, somebody with any chronic disease like COPD is going to be more prone to infection. But mainly what this is talking about is preventing infection with like your oxygen tubing, and that needs to be cleaned. It needs to be changed out. Your nebulizers need to be cleaned. Whatever the policy and procedure is, like if we change those out once a month, and teach them how to clean that at home if they're using it at home also. Okay, chronic oxygen therapy at home, benefits, and patient teaching. You can read up on that. Okay, some interventions in patient teaching. Don't forget your breathing retraining. So one of those types of things would be teaching them pursed lip breathing. Talks about it on 569, but somewhere else, I think in the assessment chapter, it talked especially on how to teach them to do that. So we're having them inhale through their nose and then expire through their pursed lips, and that expiration should be a prolonged amount of time. Their airway clearance techniques, getting that mucus up and out to clear the airways. We want them to have some effective coughing, so we're teaching them deep breathing and coughing. Also, we could be using nebulizers or inhalers to open up those airways and then perform, they call it huff coughing. I believe that's on page 569 also. You can read about that. It's just forced an expiratory technique that you have them breathe deeply from the diaphragm, so deep into the lungs, and then ask them to like huff and cough, keep coughing simultaneously. Actually, there's a table 28-23 would explain it in your book, page 569. And then also some ways we can clear those airways is chest physiotherapy. That would be like percussion and vibration. So maybe a respiratory therapist or you as the nurse can be performing. You'd have a cupped hand and be doing some percussion anteriorly and posteriorly along the lungs to break up and loosen that mucus so they can cough it out. And then some vibrations. They might have a vibrator that they can run over the patient's chest, and that also loosens up. There are some beds that even have some chest physiotherapy built into them. They would have them on the percussion or the vibration setting to keep those secretions loose. Okay, and then also postural drainage, positioning. Of course, sitting up, they're going to have a lot easier time breathing. Maybe when they're sleeping in bed, they need to prop their bed up on bricks or something to have the head of the bed elevated. And then, of course, when you're in the hospital and you have a hospital bed, you can always raise their head of bed. So that's going to help to for their breathing. You'll notice some of these people with the really severe COPD and different lung issues, they may not even want to sleep in a bed. They may be sleeping upright in a recliner. Okay, and then we have some airway clearance devices like your flutter valve or a flutter mucus clearance device. I think we had one of these in the lab. You blow into it and that flutter is, there's like a ball inside of it that moves and it just helps to loosen up mucus also. And then there's nebulation, your nebulized therapy. That could include medication like albuterol in it, or could even just be normal saline just to moisten and thin and loosen mucus. Your nutritional therapy, a lot of times people with COPD have cachexia. They are slim and they look frail. They're probably fatigued because they're using all their energy to breathe. Some other things that can affect nutrition would be altered taste. So it's going to be important for them to, one intervention is for them to rest 30 minutes before meals. And there are other things. You need to think about energy conserving interventions. So having them rest before they perform their activities of daily living. So some of those are on page 570 to 571. Of course, some of those are going to be on the test. So think about activity preserving so that they can be performing their activities of daily living. Okay, here's our nursing process, our assessment. We've talked about all the ways we can assess this person. Some nursing diagnoses that you might use. The top three for somebody with respiratory issues would be like an ineffective breathing pattern, ineffective airway clearance, and impaired gas exchange. If that oxygen and carbon dioxide is not exchanging in the alveoli correctly. So, depending on the patient, we're going to individualize each person's care plan, but just know that these are some of the ones that we would use. Then we have our planning and our implementations. So don't forget, we're not going to just put it in place interventions or implementations. Those terms are the same. When they are not healthy, we want to focus on health promotion also. So ways they can prevent. So quitting smoking early before COPD fully develops, and then our acute interventions that we talked about already, and our ambulatory and home care interventions. And then we'll look at our evaluations. So what were our expected outcomes, and have they been met? Are we keeping the oxygen saturation above 90%? Are we, are they finished with their COPD exasperation and now their breathing is less labored? Maybe it was at a 26, now it's at a 22. So maybe that was our outcome. Or maybe it has to do with activities. Their ADLs are being met because they have learned how to conserve energy. So those are just some examples of how you would use the nursing process to care plan one of these clients. And then last but not least is bronchiectasis. The etiology and pathophysiology of that is there's a permanent abnormal dilation of medium-sized bronchi that is a result of inflammatory changes. So there is a destruction of the elastic and muscular structures in the bronchial wall. So some manifestations that go along with that is persistent cough with thick purulent sputum, but not always. Probably pleuritic chest pain. Pleuritic chest pain is a sharp stabbing pain, or sometimes they call it like pleurisy would have pleuritic chest pain. Also, sometimes they would have hemoptysis, hem meaning blood, optysis meaning sputum or spit, so some blood-streaked sputum, dyspnea, wheezing, clubbing of the fingers, adventitious breath sounds, and weight loss and anemia. So a lot of these have some very similar clinical manifestations. So I guess what would stick out with this one would be the pleuritic chest pain. We would not see that in the patient with chronic bronchitis or emphysema usually. We don't hear of that with asthma either. Okay, then our diagnostic studies are going to be much the same as they are with all of these respiratory conditions. So our chest x-ray, a CT, sputum and specimens to see if, what is growing in their culture, in their sputum. And then collaborative care, you can read on that on page 581. And your nursing management for bronchiectasis, that's on page 581. And that concludes what we are studying in this chapter, chapter 28. So you'll notice some things were not covered. They are not in our objectives, so we're not going to go over those. For example, like cystic fibrosis is one of those. So okay, good luck on your test. Don't think too deep into it. Think about your signs and symptoms of each disease that we talked about. Think about your nursing management. Think about what some of your nursing diagnoses may be. Think about, as a nurse, what you need to teach the patient with diagnostic studies, what you need to be aware of with diagnostic studies. Some of them you'll have to monitor their allergies. Some of them, when do you collect a sputum specimen? How do you teach them to cough that up? Which studies would they need to be NPO for? Those type of things. I think that pretty well covers it. I think you guys will do just fine on your test.